Hello, and thank you for this opportunity. Netmark Business Services is a SOC2 and High Trust certified entity, as well as being a participant with the SBA. We are a minority business. Our C-suite consists of healthcare leaders who have helmed insurance companies, as well as TPAs. We have joined that experience with the freshest and brightest minds in the healthcare IT space. As a team, we have participated in a multitude of engagements where the creativity of diverse teams has been fundamental to our success. We welcome you to join us for the next several minutes as we introduce you to Netmark. We are going to share what we do over the next few minutes, and we both have the added benefit of being able to do that through video in this instance. As we were putting this together, we wanted to share what we tell someone when they ask what we do, for all that we do and the services that Netmark provides, whether it be through our BPO services, where we take on the entirety of a health plan's back office work, or the development of LLMs that improve the efficacy of every end user's work. Netmark is a data company. We manage, farm, convert, and turn every piece of data that we touch into action that fuels success. In our everyday lives, we are humble servants to a block of great clients who are dedicated to improving the overall value of care for every stakeholder they support. A few years ago, we made a commitment to engage our services at every touchpoint of a healthcare participant's journey. From that mission, we expanded our services of BPO and critical resource teams to include modernization for legacy technology, systems implementation for new, data collation, warehousing and analytics, and what we have labeled actionable intelligence. This is the use of AI not just as a bullet point on a sales brochure, but targeted, one-off code projects creating a new processes or specifically bridging system gaps. We have also aligned our delivery services with every touchpoint, specifically involving the healthcare participants and providers. For example, we offer call center for both sets of stakeholders, and we have developed specific processes that improve the overall experience, speed the fulfillment of information, and have a platform for delivering a robust participant mobile app. We continue to innovate, and we have added new IP to our services. One of those offerings is a project for PCP auto-assignment to close a gap in a new system implementation where the chosen platform could not accomplish the necessary task. It's not enough for the work to be completed, it is in taking that data and making incremental operational improvements every day. Case study. In a major system implementation, an adjudication engine for a Medi-Cal health plan, it was determined that the system had a significant number of operational gaps that would negatively impact the plan's compliance. To solve a particular gap, PCP auto-assignment, Netmark created a custom solution that aligned member data, multiple demographics including address, with PCP network availability and GPS coordinates to align with specifically mandated panel sizes. This one-off IP development is an important strength of the Netmark team. Through the utilization of critical resource teams, every aspect of a deliverable is contemplated, all the way down to each unique end user. How does this experience help the mission of CMS? For the moment, we'll focus on some thoughts around EQRS and TPS and the general issues of legacy data systems. Healthcare entities are historically slow to adapt to new technologies. For example, HIPAA standardized transactions were introduced in 2003 and are still not broadly accepted. The result of this is that CMS data collection is weighed down by maintaining multiple sets of historical standards. It is difficult to turn the ship when multiple anchors are impeding the progress, and the collation of those multiple data sets has to make one feel as though healthcare reporting is truly someone's personal version of Rube Goldberg machine. Back to EQRS. From the data available, roughly 50% of dialysis facilities are ranked with a TPS of below 60 and are labeled as at risk, poor, critical, and severe. All face payment reduction based on TPS. Poorly performing facilities have a negatively impact on the system and patients. The addition of data inaccuracies in EQRS, Medicare claims, or NHSN lead to measure exclusion from TPS calculations, reducing reimbursements and public quality scores. Netmark believes that we have a solution that is estimated to create a 50 to 80% reduction in QIP, impacting data errors across 7,591 facilities, a 15 to 25% improvement in dialysis session adherence nationally, 30 to 40% faster EQRS submission cycle, and a 1 to 2% Medicare payment protection per facility, equaling approximately $75 to $150 million in preserved reimbursements. Netmark sees an opportunity to put a methodology together, leading to an ongoing and efficiently scalable system to improve data integrity, thereby improving overall provider/facility compliance and reporting. One specific component of this scalability would be to design a series of dashboards that provide an early warning to facilities of TPS metrics that are failing. These dashboards would allow facilities to monitor their scoring and to make impactful corrections during a measurement period. Netmark would deploy a comprehensive ESRD-QIP/EQRS compliance platform combining IT innovation and operational execution, designed to ultimately scale across the nearly 7,600 facilities nationwide. Our solution begins with a targeted data integrity and cleanup process. This would address data quality issues across all facility types and ownership structures. Additional solution components include AI health diagnostics, ICD-10 billing validation, patient traceability and outreach, geolocation-based auto-assignment, geographic care coordination. For AI health diagnostics, this would offer a real-time detection of missing QIP measure data, ICD-10 coding errors, and patient compliance issues. This detection of anomalies in the various algorithms would drive role-based dashboards. The dashboards would serve different operational needs across the multi-facility ecosystem. There would be specific views to include provider, clinic manager, a CMS/network view, and a geographic intelligence dashboard delivering state-level analysis, market insights, and transfer patterns to track patient movement analysis between facilities and networks. All dashboards deliver near real-time insights, integrating EMR, EQRS, NHSN, and claims data into actionable intelligence, which will be directly aligned with CMS value-based programs. Of the data management, an additional gap identified is in the shepherding of data. A data shepherd acts as a central facilitator, bridging the gap between various stakeholders involved in data generation, management, analysis, and usage. This role is becoming increasingly crucial due to the rapid growth and complexity of healthcare data. As healthcare measurements and statistics grow in complexity and volumes, CMS is forced to maintain the old while implementing the new. This administrative burden of supporting grandfathered standards constrains CMS from being nimble in addressing new technology. Imagine a train pulling hundreds of boxcars, each car representing a standard of measurement or statistic. This is CMS. As new initiatives or programs are implemented, the train keeps getting slower. Likewise, as technology evolves and new measurements become available, i.e., genetic testing, the existing boxcars should be replaced with new, shiny cars. However, this does not happen. The old cars remain because the new technology hasn't been adopted across the healthcare community, further slowing progress. Data shepherding will allow CMS to focus on their modernization without leaving behind the thousands of constituent submitters struggling with adoption. Netmark would act as an intermediary that leverages artificial intelligence, AI, pattern matching, and robotic process automation, RPA, to transition any and all data from old standards to the new. Let's talk about a moonshot idea. EQRS aims to enhance the quality of care and outcomes for end-stage renal disease patients. This is an incredibly noble pursuit, and the impact on not only the patient lives, but their loved ones as well, can literally be life-saving. As we pondered our moonshot idea, we wondered if the most important goal could be to in fact eliminate the need for EQRS and TPS altogether. A lofty goal indeed, but how would that even be possible? To be honest, there will always be a need for both the collation of data as well as measurement and consequence for those providing care. Again, while there will always be individuals who suffer from kidney disease, the data has consistently shown that the presence and prevalence of chronic disease states, when combined, create comorbidities: hypertension, diabetes, hyperlipidemia, heart disease, asthma, COPD. With the presence of comorbidities, an individual is 4 times as likely to go into some form of renal failure. Our moonshot idea is a targeted, patient-centered care model, continually monitoring claims data for specific triggers that identify the diagnosis point of a second chronic condition for a specific patient. Based on AI-driven models and LLMs that are specifically geared to reference the most recent and relevant best practices of care based on the most successful outcomes for the specified comorbidities. Based on the claims history, the most appropriate care providers will be engaged with a medical care plan, MCP, designed specifically for the participant. The MCP will take into consideration a multitude of factors to improve every opportunity for success and an intervention that engages the patient and the center of care. Key to the engagement will be the use of geolocation data to develop the MCP with specific nuances of the participants' location's benefit structures, accessible providers, and centers of care that align most favorably with the highest probability of patient compliance, leading to the most successful outcome. Once the MCP has been created, it is pushed to the care team. At this point, there are a couple of components of our methodology that are more geared towards the commercial space, but are often key points to engagement and compliance. The first item is provider cost transparency. While this does not come into play so much with Medicaid, it would be an additional dataset that could prove valuable for the assessment of various payment metrics. The second component would be the introduction of a mobile app that is geared specifically to the EQRS TPS data track, with care aligned to the metrics that will also improve TPS. The app would be specifically targeted to address the chronic care management and to engage with the participant and specifically connect them to their care team. The application of the technology would be unique to CMS in that the engagement would be specific and not general. The diagnosis of comorbidity would trigger an outreach to the participant that would explain their health circumstances and identify that their team had been notified, with next steps that they need to take to engage and stay informed. An initial measure of engagement success would be the percent of participants who receive outreach and sign up for the app. Once this happens, the participant would be active in their care. Additional data to include components of care they can initiate on their own, a dashboard of their progress plus or minus, a space for medication compliance. While incentive dollars for the participant may not be a typical path for CMS, as we identified what is conceivably $1.2 to $2 million a year once a participant is added to EQRS, just for dialysis, we have hypothesized that an upfront investment could potentially keep a significant number of participants from ever being diagnosed fully with ESRD. Ohio Pilot Program. As we reviewed the various data points surrounding ESRD, QIP, EQRS compliance, the data suggested an opportunity to create a region-specific pilot program. The primary focus is on Ohio, as collectively the 321 facilities have an average TPS of 56.95. These facilities are at risk. While the ESRD network 9 services Ohio, Indiana, and Kentucky, the program would specifically target Ohio. Emphasis will also include facilities in zip codes with a higher proportion of non-white minority residents and lower median incomes, as they are disproportionately affected by low QIP scores. There would be several stages to the pilot that would include assessment and planning followed by a comprehensive needs assessment. This would include a review of current QIP performance and, in particular, underperformance. Factors will include staffing levels, expertise, and training adhering to best practices. Additionally, an evaluation of patient engagement would be performed. A final assessment of barriers to improvement would be included in the overall data collection. Each facility would receive an individualized improvement plan that will establish specific, measurable, achievable, relevant, and time-bound SMART goals for each facility. Phase 2 of the project would be the implementation and support. Through education and training, the program would drive towards best practices and specific quality improvement initiatives. Examples include promoting home dialysis options where appropriate and feasible, reducing hospitalization and readmission rates, and improving vaccination rates among patients. The pilot program would include regularly monitored facility progress towards achieving QIP goals and providing ongoing feedback and support, share best practices, and foster collaboration among participating facilities through a Learning and Action Network, LAN. And finally, conduct virtual and on-site visits to low-performing facilities, according to the iPro ESRD network. There is the possibility of developing a recognition program over and above the value of the TPS improvement to include perhaps public recognition or other incentives. Phase 3 would be the evaluation and potential expansion of the program and the geography. At this point, an assessment of the pilot program's effectiveness in improving QIP scores and patient outcomes in participating facilities would be completed. Data on hospitalization rates, mortality ratios, vaccination rates, and patient satisfaction to measure the impact of interventions would be analyzed. Finally, feedback from facilities, patients, and staff to identify successes and areas for improvement would be gathered. The results of the pilot program would be shared with relevant stakeholders, including the Centers for Medicare and Medicaid Services, CMS, ESRD Network, and healthcare providers, as well as developing recommendations for expanding the program to other facilities. By implementing this comprehensive pilot program, Ohio can strategically target interventions to improve ESRD care quality, enhance patient outcomes, and achieve higher QIP scores in facilities currently struggling to meet established standards. Both the opportunity for data shepherding, as well as the moonshot for a care team MCP and participant engagement, would be designed in to the pilot program as well. We thank you again for creating a space to present our thoughts and solutions, and we would welcome the opportunity to share our research, data methodologies, and expected outcomes with CMS. Thank you.